Hello and welcome. We will continue where we left in previous part. The learning objectives of this multi-part lecture are listed here. Please take a look. Antiretroviral therapy has evolved over years from the first agent zidovudine, a reverse transcriptase inhibitor, in 1987 to lenacapavir in 2024, which is a first-in-class drug that works by inhibiting the HIV capsid. Still, the main groups of drugs are reverse transcriptase inhibitors and protease inhibitors. Recently, WHO has approved use of lenacapavir injections twice a year for prophylaxis of HIV transmission. The NRTIs act by competitive inhibition of HIV reverse transcriptase. Each NRTI requires intracytoplasmic activation via phosphorylation by cellular enzymes to the triphosphate form mimicking a nucleotide. Instead of the normal nucleotides, the incorporation of NRTI-derived false nucleotides into the growing viral DNA chain causes premature chain termination due to inhibition of binding of RT with the nucleotide. This slide shows the adverse effects of various NRTIs. Some ADRs are universal among the group, yet others are common among many, if not all. Take a look to appreciate the similarities and differences. Zidovudine, azidithymidine, AST, is a deoxythymidine analog, the first antiretroviral agent and well studied to date, that is well absorbed, 63%, and distributed to most body tissues and fluids, including the cerebrospinal fluid, where drug levels are 60 to 65% of those in serum. Although the serum half-life averages 1 hour, the intracellular half-life of the phosphorylated compound is 3 to 4 hours, allowing twice-daily dosing. Zidovudine is eliminated primarily by renal excretion following glucuronidation in the liver. It remains one of the NRTI agents recommended for use in pregnant women, Table 49-5. Zidovudine is also recommended as an option for post-exposure prophylaxis in individuals exposed to HIV. The most common adverse effects of zidovudine are macrocytic anemia, 1 to 4%, and neutropenia, 2 to 8%. Concurrent stavudine is contraindicated due to competitive inhibition of intracellular phosphorylation. On the other hand, the NNRTIs bind directly to HIV reverse transcriptase, resulting in allosteric inhibition of RNA and DNA-dependent DNA polymerase activity. The binding site of NNRTIs is near to but distinct from that of NRTIs. Unlike the NRTI agents, NNRTIs neither require phosphorylation to be active, nor compete with normal nucleotides. This slide shows the adverse effects of various NNRTIs. Some ADRs are universal among the group, yet others are common among many, if not all. Take a look to appreciate the similarities and differences. Of note is being cytochrome P453A4 induction except delaviridine. This class of agents binds integrase, a viral enzyme essential to the replication of both HIV-1 and HIV-2, and it inhibits strand transfer, the third and final step of provirus integration. Thus, interfering with the integration of reverse transcribed HIV DNA into the chromosomes of host cells. This group includes dolutegravir, elvitegravir, raltegravir. These are generally well-tolerated drugs. During the later stages of the HIV growth cycle, the GAG and GAG-POL gene products are translated into polyproteins, and these become immature budding particles. The HIV protease is responsible for cleaving these precursor molecules to produce the final structural proteins of the mature virion core. By preventing post-translational cleavage of the GAG-POL polyprotein, protease inhibitors, PIs, prevent the processing of viral proteins into functional conformations, resulting in the production of immature, non-infectious viral particles. Unlike the NRTIs, PIs do not need intracellular activation. A lipodystrophy syndrome similar to Cushingoid appearance is common. They are also associated with cardiac conduction abnormalities including prolonged PR and quart intervals. PIs have been associated with increased spontaneous bleeding, including intracranial hemorrhage in patients with hemophilia A or B. This slide shows the adverse effects of various protease inhibitors. Some ADRs are universal among the group, yet others are common among many, if not all. Take a look to appreciate the similarities and differences. HAART stands for Highly Active Antiretroviral Therapy. This is a multi-drug treatment approach to avoid resistance and treatment failure. It comprises of at least 3 drugs but can be 4 or 5 also. Generally, it comprises of 2 NRTI drugs and 1 NNRTI or protease inhibitor, with addition of other drug classes if necessary. This is the summary diagram for anti-HIV drugs. Try to recall various drug names and relate them with viral life cycle. This is a summary diagram showing the latest drug lenacapavir targeting at several points in the HIV life cycle. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!